all, I'd like to thank the committee for the invitation to be here. My name is Patricia Rocco. I'm a full professor at the Federal University of Rio de Janeiro, and I'm elected member of the National Academy of Medicine and the Brazilian Academy of Science. Today, we'll talk about the importance of P SILI in COVID-19. I have no conflict of interest related to this presentation. We know that SARS-CoV-2, this coronavirus, enters through the nose or through the mouth and binds to angiotensin converting enzyme 2 receptors. And these receptors are located in type 2 pneumocytes, macrophages, and endothelial cells. And it triggers a cascade of inflammation that we call the cytokine storm. This cytokine storm resulted in a local and systemic inflammatory process, resulting in multiple organ dysfunction. So we may have damage of the different organs. However, the lung is the main organ affected by SARS-CoV-2, leading to a mild, moderate, or severe pneumonia. Some of these patients evolved with hypoxemia. And the first line treatment, as soon as these patients arrived in the emergency rooms, is the use of oxygen or high flow oxygen or non-invasive ventilation. Indeed, it may improve oxygenation. However, at the beginning of the pandemic, we were afraid of using non-invasive ventilation because of the risk of staph contamination. However, now it's so frequent to use non-invasive ventilation. Not only because we have this kind of control, but also we have few ICU beds and mechanical ventilators. The problem is not the use of non-invasive ventilator. The problem is to use non-invasive ventilation without any personalized control. These patients may evolve with huge respiratory effort. In this paper that were published in Blue Journal, it's with ARDS patients with non-invasive ventilation. And they measured the delta esophageal pressure. Here is a patient with a high effort and with a low effort. And they observed that the magnitude of the inspiratory effort, as assessed by delta esophageal pressure variation within the first 2 hours of non-invasive ventilation, was associated with a worse prognosis. Moreover, now in COVID-19 patients, they observed that when they analyzed the respiratory drive using this measurement, the P01, when P01 is higher than 4 centimeters of water, we may predict the relapse of respiratory failure in COVID-19 patients. And it is important to know that we have 63% deterioration within 24 hours. Therefore, the patient's self-inflicted lung injury may change the prognosis of COVID-19 patients. But how? How to interpret the mechanisms of P SILI? So we have 3 important mechanisms. One, overdistension, that increase the lung stress and the strain. The second one is the increased lung perfusion. And the third one, the patient ventilator asynchrony. Let's understand the first one. Here we have a CT scan with areas of alveolar collapse and consolidation. And in this case here, we have an increase in the delta of pleural pressure. So when we have in this dependent area more collapse, more consolidation, the effort that you have to perform in this area to open the lung is much higher than in non-dependent area. So the pleural pressure here is much higher than the delta pleural pressure in this area during inspiration. And in these regional changes, you may overdistend the alveoli and induce the damage, not only in the alveoli, but also in extracellular matrix. You overstretch the matrix, resulting in an inflammatory process, not only in the lung, but systemically. In this dynamic CT scan, we can observe in these red areas in the dependent lung, areas of atelectasis. And here, you can also observe at the end inspiration that we have a significant reduction in this area of atelectasis. When we analyze the delta of esophageal pressure, this delta esophageal pressure is much lower than the delta of pleural pressure, the regional analysis of the pleural pressure. And why this is so important? Because in this area, the diaphragm contract and open this lung. Interestingly, if you analyze the delta esophageal pressure that express the global pleural pressure, there is a significant difference between the regional and the global pleural pressure measured. So strong effort yields negative local swings in pleural pressure in the dependent lung. When we analyze the PEEP effect during non-invasive mechanical ventilation, we can observe the different mechanisms at lower and higher PEEP. At lower PEEP, here we have areas of atelectasis, and here we have non-dependent area that the lungs are open. Again, the pleural pressure in the dorsal area is much lower than when we have higher PEEP. Because with higher PEEP, we have the rectification of the diaphragm. And with the rectification of the diaphragm, you have less contraction of this diaphragm. And consequently, you have less delta pleural pressure in this area. We have a better distribution of the lung stress, less overdistension, better gas exchange, showing that during non-invasive ventilation, the use of higher PEEP, considering the regional dependent area, is better than using lower PEEP. And it may also result in less inflammation. Additionally, you have an increase in the perfusion, because when we increase this delta pleural pressure, you have indeed, through the mechanism of the interdependence, you have an increase in the perfusion. More, when we increase the venous return, you have increased the perfusion. And the strong effort generate a more negative pleural pressure, which in turn increases transpulmonary vascular pressure. And when we have a damage in the capillary, a capillary leak, this strong effort may result in a further damage of the scapulary. And you have more interstitial edema. You have more alveolar edema. Moreover, one important mechanism of P SILI has been associated with asynchrony. Here, for instance, you have the pressure, the flow, and the volume. When you have a asynchrony called double triggering, here you can see the pressure, here you can see the volume, but the most important data has been associated with the tidal volume. So you have an increase in tidal volume, and this increase in tidal volume result in areas of overdistension and more lung damage. So after you have an initial insult, such as the COVID, you have the damage not only in the epithelium, but also in the endothelial cells. You have the capillary leak, and this capillary leak result in lung edema, interstitial and alveolar edema. This results in impaired gas exchange, and lung mechanics. This impairment in gas exchange and lung mechanics increase the respiratory drive. This increment in respiratory drive resulted in P SILI, resulting in higher tidal volume, resulting in a Pendeluft, the movement of air from one area, from one alveoli to the other. And you may also increase the esophageal pressure swing. The P SILI, as I told you, may lead to capillary leak. And you have this phenomena again and again. I think that we don't need to fight with each other. Please, let's understand the mechanism of P SILI, because it indeed exists. We know that there is a strong evidence that spontaneous breathing during mechanical ventilation or non-invasive ventilation may cause lung injury. And we know that the mechanisms associated with P SILI are overdistension, increasing lung stress and strain, the increased lung perfusion, and the patient ventilator asynchrony, which may result in a mechanism of mechanotransduction with an inflammatory process, not only in the lung, but also systemically. So P SILI may result not only in lung damage, you may result in multiple organ damage. P SILI might be one of the many factors that can explain the progression of lung disease in COVID-19. Let's understand the different phenotypes. Given the shortage of mechanical ventilators, the physician must personalize mechanical ventilation strategy. It's so difficult to keep patients using non-invasive ventilation with a greater effort. Further studies are required to better understand the mechanism of P SILI in COVID-19. Concerning this subject, we are in the peak of this iceberg, and we need future investigation. We need to better understand the mechanism of P SILI, the strategies to evaluate increased effort at the bedside, and please personalize a mechanical ventilation strategy for each patient with COVID-19. I'd like to thank the group that worked with me in Federal University of Rio de Janeiro and my collaborators in different countries, as well as in Brazil. Thank you very much.